ourselves. It's a shame that we make effort, we make preparation, we leave our job, we leave our patient, and come here so that people can benefit. And who are the people who are going to benefit from these? Are the residents, are the trainees, and they're not here. So it is. I think something needs to be addressed in future conferences, whether otherwise people will stop attending them. Anyway, so I'm not going to teach you people, it's just going to share with what we have already been doing. I don't have any conflict of interest here. I don't have any. Okay, so I'll just go through background very briefly, and then I think Dr. Somaya is going to talk about the healing of healing ulcers. Corneal disease is one of the leading causes of blindness. Corneal disease, corneal keratitis is prevalent in fourth cause of blindness in the world, and 10% of preventable blindness. We know that what protect our eyes, their eyelids and the tear film and the precorneal tear film, the corneal epithelium, goblet cells, normal ocular flora, which creates a balance so that nasty flora don't affect us, and things which disrupt foreign body, trauma, vegetative methods, corneal surgeries, refractive surgeries, which are very pronounced nowadays, contact lens wear, which is increasing day by day, as we know. Just 1 minute. And lid abnormalities. I'm just rushing through because that's not part of my topic. My topic is how to diagnose primary systemic conditions, eye conditions, Stevens-Johnson syndrome. Make sure patient is not diabetic. ये कुछ change हो रहे हैं. Diabetes, alcoholism, and some organisms you know that enter an intact epithelium. We know that sometimes we have infiltrates. The blood cells accumulate and they appear as a form of infection, although they are immune complexes and they're not true infection. So I want to say that an ulcer, infective ulcer, will always be associated with an infiltrate, but every infiltrate won't have an ulcer. So make sure that you can distinguish and between these two, because healing treatment will be different. Ulcer goes through stages of progressive, regressive, and healing stages. Again, Dr. Somaya will talk about this in more detail. And we know all the bacteria and fungi and different organisms. So how to diagnose? This is the first talk. I have two talks. I'll just finish them together. We take a comprehensive history of contact lens wear, history of trauma, history of any general ill health, diabetes. So people talk about eyes, and first thing I do is talk about diabetes. And there are many corneal infections who happen in unknown diabetic patients, and we actually ask them to get their blood sugar level done, and sugar was sky high. So make sure that you pay attention to that. Slit lamp examination of the ulcer, not only ulcer, where the location, the size, the depth, and the infiltrates around. Make sure you measure it with the slit lamp, and also if there's hypopyon, measure it, because that will give you a clue towards the recovery and when it happens. Examine the surrounding area. Very important to examine the surrounding area. Surrounding area means lids and lacrimal sac, and make sure there's no blockage of the lacrimal duct and so on. Infections, characteristics sometimes can give you a clue towards diagnosis, like Staphylococcus aureus causes more infiltration than Staph epidermidis. Pneumococcus usually happen after trauma. It starts from the periphery and invades towards the center. Pseudomonas have got very copious mucopurulent infiltration, along with ring ulcer formation. A ring ulcer formation can also happen with acanthamoeba. Nocardia infection often affect post-trauma with small multiple pinhead-like lesions. Fungal infections after vegetative injury, so history is important. Along with that, you say in immune-compromised patients will always have it or can have it, and they have small lesion with a satellite lesion progressing. Acanthamoeba we know can cause severe pain, and sometimes the pain is so severe and there are no signs that patients have been labeled as malingerers, or don't say that, don't do that. Make sure to take history, you examine properly, and sometimes you see a severe limbitis before any specific infection within the cornea. You see neuroretinitis before you see the typical ring ulcer. Infectious crystalline keratopathy, it's very specific, in which instead of producing purulent infection, organism form crystalline material deposited, usually happen after prolonged use of steroid and post PK application. So we can see staphylococcal infection, lots of infiltrates with hypopion. You can see a ring abscess forming here, pseudomonas or others. You can see a peripheral traumatic injury with peripheral infiltrate spreading toward the center, fungal infection with satellite lesions, and nocardia infection with pinheads. Diagnosis, it is advisable to do the scrapings, should always be done in the slit lamp. Make sure you use least bacteriostatic anti-local anesthetic. Patient को pain होता, patient is in pain and we keep putting local anesthetic. Don't do that. Because they are bacteriostatic, so they will just make your diagnosis blurred. Make use of 15 Bart Parker blade, should be taken from the edge and depth of the ulcer, not infiltrate. Infiltrate जो होता है इसमें कुछ भी नहीं होगा, वो सारी जो sloughing होती है. And inoculate हमें ज़्यादातर gram staining and ginger staining करनी है, but also get blood chocolate and stubber rods. At least 3 plates should be there if you don't have facility for others. If you have a contact lens wearer, I always ask them to bring your contact lens and the container, and I send them for culture. Recently, I saw 18-year-old who had a wedding that night, and previous night she had a occasion. She wore contact lens. She came with a corneal abscess. And I asked her to bring that. Her wedding to many cancers. The wedding was postponed for a year, but I said it's a warning sign from under. Anyway, the contact lens is pseudomonas, copious pseudomonas culture. So she's fine now. She's fine with treatment. It was good that she came earlier on immediately. So these are the beta all dark. What happened? When you use Bart Parker blade, I use one inoculation, one blade for one inoculation. So you have plenty of them. Don't reuse the blade, please. When you touch the agar blade, it's contaminated. So always use a separate one. So get 10 or 15 जितने भी plates हैं, जितनी भी scraping आपने करनी है. Don't reuse the blade for plate. So one for one plate. And this is how you just inoculate, because the moment you touch this blade with the agar blade, it's contaminated. So don't use it again. Confocal microscopy, if you have that facility, it will help in diagnosis. You can see acanthamoeba cysts really clearly. Sometimes microorganisms can be clearly visible. Fungus filament can be visible as well, just like that. I'm just going through. Corneal biopsy, if diagnosis is still not possible, use a 6 or 7 or silk suture passing through the stroma and culture it. A lamellar dissection can be performed with a skin punch. Small trephines and femtosecond can be used, but make sure the specimen is very small, don't crush it. This is how corneal biopsy is done. So examination, culture, scrapings, confocal, and this will give you a clue, and you will be able to diagnose before you go on to the treatment. So I'll just carry on to the next one so that I finish together. Now, if you have a small infiltrates, sometimes, as I said, infiltrates can be just immune complexes. where epidermidis, staph epidermidis, with the eyes are touching, lids are touching, you can have peripheral marginal keratitis. They are not infected, their immune complexes. So differentiate between them because they will need steroids and infection will need antibiotics. So small infiltrates can be treated with steroids. Small ulcers can be treated with quinolones and with painkillers and lubricants. So don't have intensive treatment immediately for small lesions. If the lesions are very heavy, very big, you treat them with combination therapy. So once the scraping has been done, when the diagnostic tools have been used, use combination, cafazoline, gentamicin combination. You can use broad-spectrum fluoroquinolones or multiple drugs. But make sure when you start these drugs, patient put them every minute for 5 minutes, every 5 minutes for 15 minutes, and every half an hour throughout the night. Someone dedicated should be there to put these drops for them. And the first 24 to 48 hours, we have to put drops in. One thing, if I will mention later on, that what happened with the intensive drops as well. So once you get the report, you can change the treatment. So the various medicine which can be combined with their percentages, and my pharmacy is being very kind. They actually, I don't have to make anything. At Aga Khan, at South City Hospital, they both make all these preparations for. Even recently, I did voriconazole in intrastromal injections, and they prepare it for me. So that makes my life very easy. Filamentous fungi, again, natamycin is used, Candida persistens, amphotericin, voriconazole is one. This is not part, I'm mostly covering bacteria. Role of cycloplegics, very important. Cycloplegics, the patient is in spasm, ciliary spasm, so cycloplegic relaxes and helps in healing and relieve pain. Role of steroids after 24 to 48 hours of cover with antibiotic. I do use steroids. I mean, don't be afraid of using steroids. It's been suggested. It actually reduces the inflammation. It actually reduces the sloughing, and this within 24 hours, I will look very quiet. But under supervision, if you have to see patient every day, see patient every day. If you have to see the patient on Sunday, see the patient on Sunday. My teaching, where I was trained in UK, was that see the patient alternately. So make sure there are two doctors who are seeing patient alternate days, and that's how you actually can judge the improvement. Toxic keratopathy. This is what I was talking about. Prolonged use of medicine will cause toxic keratopathy. Patients still have symptoms. You see that it's getting better. Patient have symptoms. Try to reduce these medicines because they can be toxic. The symptoms can be due to toxicity of medicine rather than ulcer itself. There have been a SCUT trial, which is steroids in corneal ulcer treatment trial, and it has been shown that if it is started on day 3, one line better improvement in best corrected visual acuity can be achieved, although role in fungus and acanthamoeba is controversial. I'm not going into this, I'm not going to this is, okay. How you judge the improvement, symptomatic improvement, पहले तो patient कहेगा मैं बेहतर हो रहा हूँ, reduced swelling of the lids, reduced conjunctival congestion, chemosis, epithelial defects, all getting better, infiltrates, reducing hypopyon, that's why it's important to measure them, that if they are reducing, you know that it's better. Patient, if not responding, you can repeat scraping, etc. I'll just mention PAC-CXL. I've recently done few patients PAC-CXL. Those are non-responders, and they responded well. 2013 Dublin में ये PAC-CXL. PAC-CXL, if people know, people don't know, it's photo-activated chromophore for infective keratitis, and it has been used in other departments, but now we do use it. It actually kills with direct UV light. CXL improves corneal resistance to proteolytic enzymes. It provides toxicity against the microorganisms, so microorganisms are killed. Again, yes, it's expensive. And where I work, it is pretty expensive, so not many people want to have it, but I encourage them, and I'll show you one of the studies. There are various studies which I'm not going into details of them, but they say that you can use higher voltage for less time, or a lower voltage for higher time. What I have used is 9 volts for 10 minutes, 9 millivolts for 10 minutes, and it works. Surgical management in severe cases, small microperforation happen, so we put acrylic glue and contact lens. Now this is very important. It may be difficult to put in, but it's even difficult to remove. So yes, microperforations are dangerous, because bigger perforation you decide आपने क्या करना है. Tectonic keratoplasty, if cornea is available. A small perforation, I think full perforation may be, somebody suggested amniotic membrane. I feel full perforation, amniotic membrane is not that strong to hold the collapsed anterior chamber. It can be used in thinning, it can be used in guttering. There are various different ways of using it, multiple layers, but it's not strong enough to hold it. So cyanacrylic glue with contact lens helps. Larger perforation, tectonic graft. If you have contact patches, sometimes people have stored corneas or a scleral patch that can be used temporarily. I'm not in good favor. I feel that if you have available cornea, that should be used. Tectonic grafting or therapeutic PKP can be used. PK, large perforations, or it's important that later on when the scarring is done, when the eye is quieter, you do optical keratoplasty, which will give you a better result. And we have done a lot for contact lens wearers. So at the end, I will say always evaluate the surrounding structures. Patient की general health जरूर पूछें. Control body's responses. So infection के साथ steroids भी आप use करें. Biopsy करें, pack CXL if it is needed, small perforations, hold them, larger perforations, if there is a melt, pack CXL or therapeutic, उसमें काम नहीं आएगा, आपने tectonic grafts करने हैं. One thing is very important, and that is, in the conclusion I will say, communicate with the patient and the family, always. Don't make your own decisions, always make them part of the decision. Give them a realistic sort of expectation. Don't say, सब ठीक हो जाएगा, बस आप wait करते हैं. Everything will be fine, everything will be fine. And no, don't say that. This can happen, this can happen. We're trying to save your eye. We are trying to save your other eye. We are trying to save your other eye from sympathetic ophthalmitis. Give them that sort of fear in their mind, so they use the drops when they go home. They don't put them in the fridge. When they start feeling better, they don't come. And I'll give you the example, a person who never came, and when he came, he was so lucky to have a corrected PKP done. So always involve them. I always say, if the eye perforates, your other eye will be at risk. So we are trying with our best. God will help us, but we'll try our best. Make sure, be realistic. This is one of my recent patients with pack CXL done. It's very quiet eye now, and all the drops have been stopped. And this is that patient who actually disappeared from follow-up, came with perforation. Perforation was sealed with conjunctival flap. He healed, and he was so lucky that after doing corneal transplant, this was his result. He's still around 20/20 vision. But everybody is not that lucky. So make sure that your approach to the patient and the disease is as books teach us, but more importantly, what experience you have. Thank you very much. Question answer will be later on.
Can you just have wonderful talk?
Thank you.
Excellent. So there's just one thing. It's a corneal biopsy with the 6 or 7-0 silk. So you just pass the silk and
you just pass it through the infiltrate and send that for culture. Very simple. Everybody don't have punches and stuff.
Yeah, absolutely.
It has. Thank you.
Yes, sir.
Thank you. Very nice
Side पे आइए.
presentation and really updated.
नीचे side पे आइए.
I like it. And we always say to our residents, please take a very good history. History is very important. It will give you a clue about a fungus infection or just stuff, and always ask about contact lens history. People, they forget. Simply, they forget. Thank you. It's great. Thank you.
So thank you so much. It was a really well explained presentation.
Next up, I would like to invite Madam Smira Irfan. Her topic of presentation is corneal healing.
Assalamu alaikum everyone. So it's good to be here. Thank you Dr. Tanveer and for Dr. Huda for coming all the way from UAE and chairing this session. And I hope you enjoyed Lahore. She was very scared. People were scaring her not to go to Pakistan, but I hope you take better memories, good memories. Okay, so now my talk is on corneal healing. Cornea, to have perfect vision, we need a clear cornea. As Dr. Tanveer highlighted, I mean, it's a nightmare if we get corneal injury, corneal disease, or following surgery. It's a dilemma for all of us as ophthalmologists to restore vision. And patients are really, they are scared what's going to happen. And as he said, that we should have a realistic approach and really make them a bit scared. Yes, you should follow the treatment and you should follow the regular follow-ups, and then we'll see it will get better. So cornea is an exposed structure, and आगे कहाँ से ये हो नहीं रहा like all body tissues, they are made up of 80% water, and but all body tissues, they are protected by skin. Cornea, on the other hand, has cells which have 80% water, but it is not protected by keratin. And because of that, it is, and since it is exposed to extremes of temperature and bad weather all the time, the surface epithelium, it gets dried up very quickly and desiccates. And so to protect that, we have the tear film. And these surface epithelial cells that dry up, even if one cell dries up, it escapes into the atmosphere, but it is replaced by the multiplication of these basal cells, which are the most important for corneal healing, these basal epithelium. And this rapidly multiplying epithelial, this needs an ample supply of oxygen, glucose, proteins, and since cornea is avascular, this is supplied by the tear film. So it's extremely important for corneal healing that the tear film should be there. And what happens when there is injury is best explained by the XYZ hypothesis. Z is the vector where the surface epithelial cells are normally lost every day by drying up. And then along the Y vector, the basal epithelium, this is rapidly multiplying, this multiplies and it replaces the cells in this direction. But when the epithelial defect is large, then it needs the help of these conjunctival stem cells which are hidden in these crypts of Vogt along the limbus. So the conjunctival crypts are the stem cells. These are mended pertinent, and these are extremely crucial for corneal healing, especially in large defects. The basal epithelium has only certain potential to replace 1, 2, 3 okay cells, but if it's a large defect, then we need these healthy conjunctival stem cells. And as Dr. Tanveer said, the toxic epitheliopathy or the toxicity of prolonged use of antibiotics, combination of antifungal, antiviral, which general ophthalmologists are very keen to start all three without having a definite diagnosis. They are going to kill these stem cells. So how will cornea heal? It cannot. If it's a large abrasion, normally it should heal in 24 to 36 hours. Normally, if the limbal stem cells are healthy. But if there is already dried surface, dried epithelium with poor tear film, then how can this large defect heal? Because this rapidly multiplying epithelium, this needs oxygen, needs glucose, metabolites, because it's rapidly multiplying. So that is the main reason, a lack of tear film for corneal non-healing. So in every patient that comes to you with a large epithelial defect and a dried eye, you are going to be very scared that how is it going to heal. So if one cell, the normal process of corneal healing in a clean cut case, clean abrasion or after surgery, clean cut surgery is one cell is lost, the basal epithelium from the surrounding, it multiplies and it migrates, it develops these pseudopods which go and secretes the fibronectin, which is a substrate material, which goes down like a hanger. And then one cell goes and it picks up or pulls the next cell and the next cell form all around till the whole epithelial defect is lined with this basal epithelium. And when this is lined with the basal epithelium, then basal epithelium multiplies and it makes these polygonal cells, and these polygonal cells then go and regenerate these apical 4-5 layers of apical epithelium. And that's how the whole process it occurs and it regenerates. But important thing to remember is that this basal epithelium is anchored to the Bowman's membrane by these fibrils. So once the basal epithelium has lined this defect, then it regenerates the basal lamina. The basal lamina is secreted by the basal epithelium. And this basal lamina is adherent to the Bowman's membrane by these pegs, which are secreted by the basal epithelium. So until and unless the whole basal epithelium and the basal lamina is secreted, stromal healing cannot take place. It has to take place. So why should a corneal ulcer not heal and progress from here to this horrible looking thing, or lead to perforation, or lead to a non-healing epithelial defect? Why? You have to look into the causes. So first we go to the stages of development of healing of a corneal ulcer. That I told you of a simple abrasion. So if there is a corneal ulcer, what will happen? First is the stage of progressive infiltration. That there is vasodilatation. In response to injury and in response to the infiltration by these bugs, there is liberation of chemotactic material and leukotrienes and chemotaxins, which result in vasodilatation, so that polymorphs, which are our first line of defense. You must have read in your 4th year in medicine that polys are the first line of our defense. They are called upon into this area so as to kill these bugs. So this killing then produces pus. And if there is pus or there is infiltrate, you know that this is not an abrasion, this is an ulcer. So this pus is actually formed by killing of polys with bacteria. And this killing then releases proteolytic enzymes. And those proteolytic enzymes then keep on digesting the remaining epithelium, as well as the Bowman's membrane, as well as penetrate into the stroma. So unless this killing is not controlled by your good management, by your adequate antibiotics, and removing this slough, clearing this slough so the antibiotics can penetrate the hidden bacteria under the slough, this process will continue and the ulcer will deepen and deepen. So the stage of active ulceration is there is necrosis of the epithelium, then the Bowman's membrane, and then the stroma. The ulcer will keep on progressing. Unless it is controlled, this whole killing process is controlled by your good management. So if it is controlled and you are efficient and diligent, then we go to the stage of regression, that further killing stops and the further migration of polymorphs is stopped, and then lymphos and the macrophages come into play. And these macrophages, they clear the ulcer base and they remove all the necrotic material. And once the necrotic material is removed, at the edge of the ulcer, the basal cells are not made toxic by your aggressive approach, by being given antibiotic, antifungal, antiviral for months. I've seen given for months, which is killing to the basal epithelium as well as to the limbal stem cells. How is this going to heal? If this is not going to heal if there are no stem cells, and this will become an epithelial, non-healing epithelial, chronic epithelial defect. So for this to heal, we need macrophages, fibroblasts, and they will go in the area and they will make the scar tissue. So stromal healing starts once the epithelium has healed. And once the epithelium means the basal cells, the basal cells, when they are healed, they will secrete the epithelial basement membrane, which releases growth factors, which activate keratocytes, and keratocytes then become fibroblasts, and that they lay down the collagen. So unless this happens, the epithelium is not healed, or these keratolytic enzymes, proteolytic enzymes keep on going to the stroma and keep on melting it. So this has to stop. This has to fully heal, and then the stromal healing starts. So this is the essence of corneal healing. So if you want to avoid this, a large persistent epithelial defect with rounded borders, with the loose epithelium, because there is no substrate, and there is no substrate where this epithelium can grow. That I showed you, like an anchor pulling one cell to other. There is no substrate, no basal cells, and this cannot heal. And if there is persistent stromal haze, because of lack of growth factors, lack of fibronectin, continued inflammation. Inflammation is now, it's not by active infection, it's the toxicity and the neurotrophic cornea. Ulcer is so painful because one nerve ending is exposed. The cornea is the most healthily supplied tissue with 7,000 nerve endings per cubic millimeter. And imagine those nerve endings are exposed, so it's painful. And if that pain actually releases growth factors, and it releases all these mechanisms to promote corneal healing. So there are no nerve endings in a neurotrophic cornea, in a diabetic cornea. So how is healing going to occur? It will be stopped. So that is also an important factor of non-healing, and that mainly occurs in diabetics. Now all our 40 to 50% population, elder population is diabetic. So in diabetes, the cause of poor healing is these lack of nerve endings, neurotrophic cornea, and lack of growth factors. And then there is toxicity because there is no limbal stem cells left to heal. So you have to moderate your treatment. As Dr. Neil rightly said, you have to give steroids to reduce the inflammation. And so that the limbal epithelium, this has a chance to breathe and start regaining its function. Kya hua ji?
It's healing.
So when a patient comes to you, you have to it's extremely important to look for the predisposing causes. Number one, diabetes, you have to find from history, or there is malnutrition. Corneal healing, it is a highly metabolic process, highly active metabolism is required. And in diabetics, the metabolism is already gone to zero. So giving insulin eye drops is a good idea. I don't know if Dr. Neil is giving. Insulin, lack of insulin, if there is no glycogenolysis, no glucose, metabolism is all haywire, and glucose is needed for this active metabolism, active healing. So insulin eye drops, the normal insulin, you get 1 unit 4 times a day, and especially in diabetics, and this persistent epithelial defects, they heal. You look at the tear film, if it's absent and it's a dry cornea, then you have to replace with lubricants. Number 3, an important, extremely important cause of non-healing and persistent inflammation is meibomian gland dysfunction. The meibomian glands, they are loaded with bugs, the low-grade infection is there. There is continuous supply of these less virulent bacteria, the staph epidermidis, from the meibomian glands. And unless you treat the meibomian gland infection along with treating the rest of the ulcer, you will have a continuous supply of bugs, and that must be taken into account. आने है कि नहीं? सारे मेरी तस्वीरें. So, I mean, my Bowman gland dysfunction, I get referred patients from all over with non-healing cornea. So, I don't know, Dr. Nveer, you must have seen all of them have my Bowman gland dysfunction. And I treat that, and the cornea starts healing. So, I mean, it's so damn important in all the ocular surface infections that I've taken a full IC tomorrow. So on my Bowman gland dysfunction, how to diagnose it, how to manage it, because this is the main source of bacteria. Bacteria wo asman se nahi aate, the very virulent ones, okay, yes, but mostly 80% corneal ulcers are from the normal flora, because the cornea has been damaged maybe by an abrasion, by a fingernail, or the farmers, the fungal injury is less. It's the normal flora that invade a dried epithelium. One epithelium cell is lost, it is not replaced. So it is a source where bugs can land, penetrate, and cause disease. So unless the bacteria they land, or the viruses they land on the cornea and penetrate the cornea, they cannot produce an ulcer. And that only happens once the tear film is not there. The normal epithelium, surface epithelium is lost by dryness, and the bugs can attach, they attack, and because the tear film protective element is not there.
Sorry, I make experience with the new drops of vitamin B2 and B12.
Yeah, in all these patients, I give vitamin D. And vitamin C that you have to give. Vitamin C is anticollagenase. So anticollagenase has a very important role in non-healing ulcers, and these anticollagenases are in ascorbate. Unfortunately, we don't get ascorbate drops, so if you can get hold of the vitamin C injection, you can make the ascorbate drops. Then acetylcysteine eye drops, they are excellent anticollagenases. Tacrolimus, an amazing anticollagenase and promotes corneal healing. And of course, don't forget the lubricants. Lubricants, if they are not there, cornea, we are blinking. The patient is blinking all the time. Every time it blinks, the epithelium that is trying to heal, it will break up. So without the lubricant in between the lid and the cornea, epithelium keeps on breaking up. So lubricants have a very, very important role.
Samira, one thing I want to add is ascorbate drops. I mean, we can prepare them. They're very, very stingy.
Stingy?
Very stingy. I do request my pharmacy to make them for me, especially for chemical burns patient, but not for ulcers, because vitamin C generally they actually sting like hell. Tetracycline. Tetracycline is a very, very good medicine in such cases. Longer use of tetracycline actually heals. So these are the things which we may don't even think about, but these are the things which helps. As I said, as Dr. Samar said, general health, improved general health, you will see healing will take place.
Tetracycline, I mean, it is mandatory for this meibomian gland infection, and that's why ointment as well as orally you should give for at least 6 weeks. The course is 6 weeks, and ointment you massage, the patient massages in the eyelids, and the oral doxycycline 100 milligrams daily. I mean, it won't kill the patient. One capsule daily. That is very, very important. And acetylcysteine eye drops, they don't sting. So if ascorbate is stinging, I think it's because that's a hyperosmolar drop. So you can reduce you can dilute it. So what I do is I make them myself, all of them. So if it's really very stingy, then we can reduce the concentration. You can add more distilled water, or you can put even ascorbate, because all these eye drops, they have an osmolarity of 300 milliosmoles. And if you add something into it, the osmolarity becomes very high. And if the tear film is already not there, these hyperosmolar eye drops, they cause stinging. So that's why people used to recommend in literature to give acetylcysteine 10% drops. My God, 10%, it's killing. And even 5% acetylcysteine a patient cannot tolerate. What I'm making myself is 0.3%, and that does the trick, and it's very gentle to the eye. So okay, so we got it. So in this, so you have to restore the tear film, and you have to control the inflammation, autologous serums sometimes. Once the infection, okay. So why perforation occurs? Perforation occurs because the infection is on the cornea. It's not restricted here, it is going into the aqueous, and in the aqueous there are all these proteins. And proteins, they make the whole aqueous sticky, peripheral iris sticky, and they adhere to the peripheral cornea, making PAS, and that PAS, they result in high pressure. The integrity of corneal epithelium is already reduced. ये इससे आगे हो जाता है क्या मुसीबत है? Anyway, the integrity of this corneal epithelium